So some of you might be familiar with this infographic. There's several that's floating around. There's another one with the apples in the tree. But equality, and I'm sorry if I'm stating the obvious, but I think if I'm doing an EDI workshop, I do need to state the obvious. Equality is when generally we all have equal opportunity and the same levels of support from different segments of society. But equity actually refers to, and it goes a step further, it recognises that we need varying levels of support for different people from different protected characteristics to achieve that fair outcome. And if you look at the last picture, because I do like that, people are now starting to talk about justice. So actually, what can we do in society what things can we do that remove barriers for our patients so that we've got better access of healthcare, and what can we do to reduce the health inequalities that persist in our societies? So this is my next challenge. If you can just go to, and it's only a bit of fun just to keep us all a bit entertained and that I'm not talking all the time. If you can go to menti.com, and if you can put in the code 4807 2833. So the first question should say, which of the following is not a protected characteristic under the Equality Act? I told you it's quite a very straightforward, simple quiz. So I think, yeah, we're all getting there. There's 9 characteristics and obesity is clearly not one of them. Okay, so discrimination on the basis of a religion cannot occur when both the alleged discriminator and the alleged victim have the same religion. That's false is the correct answer. It can definitely occur even if you have the same religion. So thank you for doing that. It was just really trying to get a grasp of where we are. Right, so why does equality and diversity inclusion matter? So some of you might remember this campaigner, I think her name was Lynn Kelly, from last year, and actually it's gaining momentum now. She's quite emphatic campaigner when it comes to issues relating to those who are hard of hearing. And she is seeking legal action now against the government because I think the first 2 coronavirus briefings didn't have anyone doing any signing for the deaf community. And when I listened to a documentary on her story, I actually thought, goodness, I can remember those early days when no one knew how COVID was going to take a grip of the country, and every day we were seeing the daily toll of death figures going up and up and up, and not being able to hear what was happening, but clearly being able to sort of visually see the figures going up. That must actually have been quite a frightening scenario. So why is EDI important? Well, firstly and foremostly, it's actually a constitutional requirement. So it's part of the NHS Constitution from 2012. And then you'll be familiar with the NHS. It's the key stage of the framework that employers use, particularly when they're doing your appraisals, your staff appraisals. And the 6th dimension of that appraisal embraces equality and diversity. But then we also recognise that practices where staff really, I mean, I often get, we are quite a diverse bunch of people, but how inclusive are you as a practice? Because we're finding that the more inclusive practices are, there's definitely a reduction in staff absence and turnover, and there's an improved flexibility of roles, that staff morale is high, health outcomes are good, performance outcomes are good, and access is also quite improved. So there's lots of evidence around that to support that. So I'm just going to give you a quick story, and I've done this exercise at our spring conference in Yorkshire and elsewhere. I don't think I did it in the Midlands, but if you've heard this before, I do apologise. So if you can, I get people to close their eyes, but don't worry about closing your eyes. If you can imagine this scenario where you have a GP trainee, which we'll call him John Doe for now, and he comes from a small village, and John has always aspired, as people from his village do, to become a doctor or engineer or something in the science field. But he's really struggled with his training, and in fact it's taken several attempts to get through his RCA, but he finally passes it on his 4th attempt. and he's a couple of months off qualifying and gaining his CCT. And you're sat with your trainee, and the CEO, because you're in one of these super partnerships, comes in and says, right, John, we really do value your input in the practice. You're a popular team member, you get on with patients and the staff. Our senior partner is leaving, and we'd really like you to join the team as a salary GP, if you want, with a view to partnership. And John says, well, actually, I'm really humbled to think that you want me on the team, but I am my partner expecting a baby. We've been trying for quite some time now, and I was hoping to kind of just go down the locum route to give my partner some flexibility when the baby comes. So that's the scenario. Now, in your mind's eye, as you're picturing this scenario, and I picked this up from an author who writes for the Huffington Post called Valerie Alexander, who's very good. And in your mind's eye, I would ask you, had you pictured John as a white male trainee? Had you pictured him as someone who's in a same-sex relationship, expecting their first child through surrogacy, perhaps? Had you pictured the senior partner that's leaving the practice, who John has been asked to replace? Does the senior partner look like me? And does the CEO, would you imagine that actually that CEO was a young ex-female banker who uses a wheelchair? Now, I won't ask for a show of hands, but I suspect that perhaps some of us may have not had that imagery in our mind's eye. And that's absolutely fine. That's okay, because we will always default to the things that we're used to. That's just human behavior. And I guess what I try to do, particularly through some of the race equity workshops, is to encourage us to think about our individuals in a different way, if we can. If you can look for, there's a lawyer who deals with lots of EDI. She's called Joan C. Williams, and she talks about the 5 main ways that we need to challenge bias in the workplace. The first one is what she calls it the prove it again theory, and that's to do with, so for example, you'll hear that when people apply for certain positions, there's lots of evidence to suggest that if you have an anglicised name, you are more than likely to be recruited than if you don't. And then she has she calls a tightrope theory, and that's particularly pertains to women in the workplace. And what she means by that is men are often, and I apologise, I'm making stereotypes here, but men are probably seen as more assertive and ambitious when compared to women. And if women were to show the same assertiveness in the workplace, they are sometimes seen as being abrasive, and that's not always a very good thing to do. So I've just realised I'm blocking the third picture. The tug of war. What that relates to is when you get a situation where you have people from a particular characteristic. So for instance, women, I'll use women again, or even people from the Black and Asian minority group. What happens is the group fuels conflict within the group. And what I mean by that, you may find 2 women who are at the pinnacle of their career, or 2 women at the pinnacle of the career, and rather than us accepting and sharing that same space, we often feel that only one of us is allowed to be there. And whether that's because we have internal insecurities, or if there's an external perception that, well, we only just need one person there to tick a box. So there's that bias. And then you have the racial stereotypes. For example, there's the stereotype of the angry Black woman, or the mistrust of the Asian man. These are racial stereotypes that we do know exist. And then we also have the maternal war. So you'll have perhaps women that come back from maternity leave, and I hear it all the time, you know, oh, I don't feel I know what I'm doing because I've got pregnancy brain, is I think what the terminology is. So that's a very real bias that we know exists. So what are the difficulties that we have in primary care? Now, the NHS Equality, I need to get this terminology right, the NHS Equality and Diversity Council a few years ago, I think it was in 2014, they agreed to ensure that employees from the Black, Asian and minority ethnic group had equal access to career opportunities, and actually they allowed this data to show that people were receiving fair outcomes. And so there's nine, I think it's nine criteria that the Workforce Race Equality Standard has. And there's also now a Workforce Disability Equality Standard. And that has a specific set of 10 measures which enable NHS organisations to compare the workplace experiences of disabled people versus non-disabled people. And they make year-on-year comparisons with that data. Now, currently at the moment, a few years ago, we did this, I think evolved in 2016 particularly. This is all quite trust dependent. So a lot of hospital trusts, and I call them the big beasts, because whenever you're in the room with them, they feel like they're slicker machines. They've got the trust, they've got the funding in place to have the EDI champions in, the freedom to speak up guardians there, and they're able to effect this data and get it ready so that they can be held accountable essentially when they look back. We are quite some way away from achieving this in primary care, but there are a number of people that I know are passionate about this, and there is a workforce group that's been that's in process at the moment trying to redress the balance, because we know that if we look after our staff and give them equal opportunity, that definitely has a role to play in reducing the health inequalities, particularly in those areas that are underserved. My daughter asked me, I put this slide in because she said to me, right, she's only 12, Mummy, E, D and I, you've explained what it is to me, but which one's more important? So there I was trying to think about, would I rather have this, that or the other? And I thought, and she said, surely they're equally important. I felt, oh God, here I am just about to deliver this and my 12-year-old's telling me what to do. And it's so true, because I hear it all the time. We are a really diverse group of people. And I say, well, yes, that's great. But when you look at your staff in terms of the diversity that you have, what leadership opportunities have you offered the women, for example, because I see it as a woman, I have a bias, because I'm quite conscious that sometimes we don't put ourselves forward well enough, put ourselves in places where we ought to be, and because we don't feel that we could do it for whatever reasons, and there's lots of reasons behind that. But more importantly, if we don't address it, there is real evidence to suggest that if people continue to receive unequal treatment in the workplace, it can make them sick. And there's real evidence of that. If anyone attended the college conference, I think they had a professor called David Williams. He talked about the concept of biological weathering, that things like the unconscious biases or the microaggressions can impact on your health. Oh, and there you go, the microaggressions little video. So some of you might have seen this already, but I'll just play this as a bit of an icebreaker, and then I can have a sip of water in the interim.
For people who still don't think that microaggressions are a problem.
Oh, you're so well spoken.
Just imagine, instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while...
No, where are you really from?
Cleveland?
Sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date...
Oh, your English is so good.
Excuse me?
Going grocery shopping.
Everything happens for a reason.
I'm just buying apples.
Commuting to work.
So when are you gonna have a baby?
Watching TV.
We have to keep the Redskins name. It's part of our culture and history.
Or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
Do you know John? Give me shopping advice. I love Cher too.
And getting bit by mosquitoes every day.
Can I touch your hair?
Multiple times a day.
So pretty.
Can I touch it, please?
Can I please?
Is annoying. And makes you want to go ballistic on those mosquitoes. Which seems like a huge overreaction to people who only get bit every once in a while.
It's just a mosquito bite. Who cares?
Just another angry black woman.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try less challenging, Major.
dreams.
And other mosquitoes carry strains that can even kill you.
He looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
Right, so thank you for that. I actually wanted to, in the last slide, actually mention, particularly with the health inequalities we've seen around the approach to the COVID vaccination, particularly in areas where I live in an area where it's quite bizarre. We have a coastal practice, which is quite remote, quite deprived area, and then we've got a semi-rural village, and it's been quite challenging in some areas to get people to acknowledge, but I mean, we're getting better at it in terms of accessing the vaccine. I know I've been part of several groups, and I'm so impressed with your chair, Carter, so please do let him know, Zenaida, because he's been phenomenal in terms of what he's done, particularly through his social media networks, to engage his community to take up the vaccine. And I think it's just really, really important, the fact that we do have that diverse leadership in your LMC, because that's not something that's reflected around the country, and in the college as well, has been, I think, a real game changer in terms of engaging specific communities. Okay, so next slide. So this brings me on to the Equality Act, which again, I think I'm just teaching you all stuff that you know, I'm not teaching. So you'll be aware that it was devised in 2010, and essentially it's there to protect discrimination from people in the workplace. And it's an umbrella act, because I think there was about 116 different types of act at the time that people just couldn't get their heads around. So it's just brought all these 9 protected characteristics under one group, and it makes it easier for people to understand what the law actually is. So it starts off with so there's 9, so we've got age, and I always have to look at pictures to remind myself. We've got age, and I think in the Warriors, about a fifth of GPs at the moment are under the age of 35, and around 20% are aged 55 or over. And there's a real concern from college, especially with the over 55, about retention at the moment, but I appreciate that's a separate argument. So age is one characteristic, sex, sexual orientation, marriage and civil partnerships, gender reassignment, pregnancy, maternity, and disability as well. Right, okay. So this is what I spent my whole weekend doing, and it just doesn't look as good as I thought it did. So on the outside of the purple phase is all the protected characteristics. And what I was trying to demonstrate in this was that there's a degree of intersectionality. So some of you might be familiar with this term already. It was a term that was coined by Kimberly Crenshaw a few years ago, because we don't all just fit into one particular box, or several of us may have several characteristics, and a lot of how we are is shaped by our lived experience, where we were born, where we grew up, our education and social status, and all the rest of it. And that's a really important thing to consider. And how do we take these things into consideration in the workplace? And out of the Equality Act evolved what is called the General or Public Sector Equality Duty. And it has 3 main aims. One is to eliminate any form of unlawful discrimination. The second is to advance the equality of opportunity between people who share a relevant characteristic and people who do not. And the third is to foster good relationships between people who share a protected characteristic and people who do not. So eliminate unlawful discrimination and advance equality of opportunity and foster good relations. So I'm just quickly going to talk a little bit on, maybe get some interaction from you, because I can feel myself losing my voice slowly, I don't know why, on the types of discrimination that we have in practice. So direct discrimination, which is probably the easiest one to define. Does anyone want to have a stab at defining direct discrimination?
So refusing to employ somebody or interview somebody because they're from a particular racial background.
Absolutely. And so that's as plain as it could be, really. So absolutely. And direct discrimination by association. So refusing to employ them, using the last example, because perhaps maybe they have a child that's disabled, or they're married to a someone from a religion, any religion, a Muslim or Sikh or Jewish. Direct discrimination based on perception. Anyone want to have a stab at that one?
When you discriminate against somebody, say they've got tattoos, and you assume people with tattoos are sort of people with wild characteristics and maybe not sort of conforming.
Yeah, thank you, Khalid. Yeah, absolutely, absolutely. And then discrimination arising from a disability. That's I think that's self-explanatory. So I've missed out indirect discrimination. So that would be. So I always find it difficult to explain this one. So imagine if you were advertising for an administrative post, but you asked the candidates to have GCSEs, 5 GCSEs above a certain grade, then you have to remember that not everybody has done GCSEs. I think they only came in 1988. So you're actually discriminating against people who've never done a GCSE. Harassment. Again, I think that's the term is self-explanatory. Victimization, some people do get a little bit confused with the term victimization. Does anyone want to hazard a guess or try and define victimization? So this one, I won't let you suffer too long. This one is when, so if you were to make a complaint about the culture or the working practices that you're in, and then later on down the line, or whenever you are in your journey, you are denied an opportunity, any opportunity within that culture because of the complaint that you made against that organisation. So that would be termed as victimisation. Now, there are some types, so all direct discrimination, harassment and victimisation are illegal, so they're not lawful. But there are some cases where you can have indirect discrimination, which could be lawful. So I can think of a couple of scenarios. I don't know if anyone wants to try and have a stab at this one.
I think, for example, in the army, there was particular roles in the army that women couldn't do, such as frontline, things like that.
So I think using that example, Joe. Hi, Joe. It's nice to see you here. I think that would be termed as direct discrimination, in my opinion. I would have to seek legal consult on that. So I'm not quite sure I could define that as indirect. I was thinking perhaps something like if you had someone with a stammer and say it'd be difficult to justify having that individual working in a situation, say a call centre answering emergency 999 calls, because the stammer would effectively lead to delay in someone accessing emergency care. Angela, did you want to come in, and then Khalid?
I was just going to ask, what about things like positive discrimination for particular roles where you're trying to increase, I don't know, people from a particular background? I was just wondering whether that would fit in as an example. I don't know.
I think if I'm right, positive discrimination is also in this country, and somebody correct me, is unlawful. We go down the route of positive action. Now, I know in America, because this all came out of the John Rooney rule with the American Football Association, that positive discrimination does, it's legalized, but it's not legal here yet. And I do know it's been difficult, particularly in educational circles, because I know you're with Health Education England, to try and get particularly our training program directors to get more diverse reflection, because a number of our trainees are increasingly coming from the sub-Saharan African continent or Southeast Asia. But I strongly suspect that they'd have to go down the route of positive action.
Thank you.
Khalid, did you want to say something?
No, I was going to say something similar, but can you kind of explain to me the difference between positive action and sort of discrimination? I kind of struggle with these kind of two meanings of that. I mean, Labour have some shortlist, that are female-only shortlist for the MPs. I mean, according to what you've just said a few minutes ago, that would be illegal.
Yeah, I'm not. So again, I admit the things that I don't know. So it's a really good question, and I'm not trying to avoid it because I will get back to you on that, particularly with regards to positive discrimination. But I have read up and I have been told that, you know, you cannot positively discriminate against people. So for example, if you're a practice manager, you can't, and you're worried that you don't have any male receptionists, you couldn't advertise for just a male receptionist when there are more qualified female receptionists in the community. That would be unlawful. But I will find you a more definitive answer if Labour are indeed doing that, because there must be, I imagine, some legal loophole that they're using to get around that. So that's my on my to-do list. Thank you, Khalid. Okay. If anyone's got anything else they want to shout out, then please do. The following two, and I'll forward the slides on to Zunaida, so don't feel you have to scribble anything down. The following two slides are just going through each protected characteristic, and as your organisations, what the law prohibits at work for each of those characteristics as an employer, but also as what the law prohibits in relation to your patients or service users. So I'm just keeping check on time, which we've got quite a lot of time left, so that's good. Okay, so does anyone know, feel free to just put a show of hands up, what the NHS England Equality Delivery System is? So, and I'm laughing because I had that face until I was asked to do this. I was like, so essentially they have, there's this, it's EDS2 now because this superseded the first one that came out in 2013. It's a framework that everyone can access to show us as organisations within the NHS how to comply with EDI law. That's essentially what it is. What I'll do is I'll quickly play this because it's not long, it's only 3 minutes, because it centres around 4 particular domains. So I'll just check my shared sound. Yep.
Assemble evidence. Equality lies at the heart of what we believe about the NHS, its values, processes, and behaviours. This is why it's important we build a service that puts patients at its heart and removes barriers that stop nurses, doctors, and other NHS professionals working to their full potential. We need to recognise that every patient has different needs and circumstances. We can best meet those needs by delivering a personal form of care that treats people with the dignity and respect they deserve, using and supporting the diverse talents and experiences of our workforce. That's why we want all NHS organisations to use EDS2. EDS2 has been designed for local NHS organisations to improve their equality performance for their patients, communities and the workforce. It also helps NHS organisations to respond to the public sector equality duty. From April 2015, EDS2 is included in the standard NHS contract for NHS providers and in the CCG assurance framework for clinical commissioning groups. To attain higher levels of continuous equality improvement for all patients and the workforce, EDS2 should be implemented consistently across all NHS organisations. There are 9 key steps to help. Confirm governance arrangements and leadership commitment. Identify local stakeholders. Assemble evidence. Agree roles with the local authority. Analyse performance. Agree EDS2 grades. Prepare equality objectives and more immediate plans. Integrate equality work into mainstream business planning. Publish grades, equality objectives and plans. The new EDS2 summary report template can help with the final step. Organisations are encouraged to complete the template and to publish it on their websites. For details on the 9 steps of EDS2 implementation, NHS organisations should follow the EDS2 guidance document. EDS2 is there to make sure everyone counts, so we can grow a healthy NHS with a strong, vibrant culture that all patients, the public and our workforce need and deserve. The Equality Delivery System for the NHS, EDS2, making sure that everyone counts.
Thank you. So yesterday I went into, so Jo Welsh, so I'm going to embarrass you, she's our HR manager, and I said, EDS2, have you heard of EDS2? And it's been around since 2013, so I was quite surprised. And so I started doing a bit of digging, and actually our CCG does have an equality impact assessment statement on there. So I'll come back to these in a minute. So does Nottinghamshire CCG. They have a whole policy, and the policy, if you haven't read it, is actually a really good policy, and it's worth just having a look at their impact assessment statements that they've made on their website as well. So I've read through at least half of that, because I've actually found it quite interesting, because I'm sad like that. But the EIA, the Equality Impact Assessment form, is there, and they're quite useful to use, and maybe could provide us with a good framework in terms of how we as primary care organisations deliver that, whether we maybe do that as individual practices or PCNs. That's perhaps something that we need to have a think about from different practices. Salary GP was returning from a period of maternity leave, and she was tearful because I think the first day she was coming back to work, she was on call, rotated to be on call. Now, I just wondered from the group, how would you normally prepare for anyone coming back from maternity leave within your workplaces? Anyone want to share what they do?
When our staff have been on maternity leave, we do a full induction with them on the return, because COVID or no COVID, it's a long period of time and a lot's changed. The confidence has dropped, and we just feel it's the best way to reintegrate them back into the workplace.
Thank you, Jo. Yeah. Anyone else?
Yeah, we do something similar, but really the practice manager gets involved with the ladies off on maternity leave prior to coming back, and sort of saying, look, do you want to come? How do you want to do it? Do you want to do it partial return to work, full return to work? Do you need, the first few weeks is how would you like to run the practices, your lists and that sort of thing? Do you want half a list size or a full list size? When do you want to be on call? So it's kind of a joint sort of discussion prior to the person coming back.
Yeah, that's great. I think, and you need to have those discussions before they come back. We used to have, I think they were called KIT days, keeping in touch days, that we used to have, which I found really useful. I've fallen behind on doing this, and I'm ashamed for doing it. But one thing that was so effective, when anyone came back on maternity leave, I'd have a pack. So it was, here's what you've missed, like a kind of little manual of stuff that's happened, and there'd be a bottle of wine, I don't know if I'm allowed to say that, and there would be and then a mother's guide back into the workplace as to how to just cope with the whole kind of mayhem, and something naughty in there which I probably can't repeat in this room. So yeah, but that was a nice way just to include people back into the workplace, and I thought that was quite good, and that's something I need to get back into doing. So the other thing I'm going to just close on quickly is this. So it's all well and good having all this stuff in place and thinking about it, or starting to think about it. But one thing that I struggle with, and that's why the RES indicators or the WDES indicators are good, is data and metrics. I often find, and I'm impressed, I mean, there's lots of things that have not impressed me with the whole handling of the pandemic, which I won't go into, but one of the things that we can't get away from is a target was set to deliver the vaccines to a particular population, and it's been met essentially. It probably exceeded that expectation. And I strongly encourage us to think about doing the same for EDI. In other words, I think we have to start thinking about what is it that we'd like to achieve within our practices that we feel meets our EDI agenda. So we're including everybody, because it's not just about the ED and the I, it's about everybody. And how are we going to hold ourselves accountable to this? And one of the Scottish chairs, Carrie Loonan, our former chair, she always used to say, when you start a meeting, ask yourself, who's missing? Who else should be at this table? Why are we all doctors sat at this table? Have we identified any PAs, any HCAs who could be potential leaders, who may consider leadership positions? Because the face of general practice, as we know, is changing. It's a very dynamic landscape. And if they're not here, why are they not here? What can we do differently to make sure that they are part of this discussion? So, and you can do that through every stage of practice activity, right through from when you're recruiting them. I remember we had, not the practice where I am now, but they used to just get someone to anonymize the names of people applying for any position. So they were really just focused in on what the credentials of that individual were. In your staff inductions or your appraisals, we know definitely when staff are being appraised, particularly when you look at those biases that I mentioned at the beginning, it's known that if you're a white woman, you are less likely to declare what you want to aspire to in the workplace. So, for example, there's a really good book called How Women Rise. If you can find that book, it's Sally Henson, and she talks about affirmation and owning it. And by that, she means this. I've had situations where you'll have a GP trainee that comes in, becomes a salaried doctor, male, and will always start the word sentence with, when I'm a partner, so and so that story becomes his narrative, which is great and is a good thing to do. Equally, you'll have someone who's equally qualified, hardworking, but as a woman doesn't perhaps tend to sell herself as much. So when it comes to the recruitment process and your management board or your partnership are looking for the next partner, who's on their radar? And you'll get women come to you and say, well, actually, I would have liked to go for that position. And then you say, well, we need to be kind of, singing. We shouldn't have to, but it's just something that we ought to be empowered to do. But maybe you can slip that into an appraisal process when you are appraising your staff, with regards to what do you feel are your next steps. Even if there are none, that doesn't matter, but at least you've asked the question. And looking at every stage of engagement, whether it's teaching or training or communication, constantly using that EDI thread through what you're doing. So I have something called the TALK EDI model. So TALK is for just talking about it and taking ownership of the situation, acknowledge that it exists and act. Just don't make assumptions about people, because we all have those inward biases. So let's look inwards at what our biases are. There's lots of tools out there. There's the Harvard Implicit Association tool you can do to check your biases. Listen to what people are saying outwardly, and we will make mistakes as long as we learn from them, but we will make mistakes, and we can educate ourselves through knowledge, because that is key. Look at the evidence. I know one thing that I hate when something happens, people say, well, prove it again, but sometimes we do need that evidence and data to hold ourselves accountable. So we need to be inclusive, involve people, because when you do that, you will inspire your workforce. So this is my call to action to all of you out there. Do you have a policy for any of these protected characteristics, or just a general, what's your EDI agenda for the next 3 to 5 years? Are your staff aware of this? Do you know what your challenges are? And how will you know what you're doing is having any effect? And how will you keep it going? And again, I mentioned you have these organisational beasts, I shouldn't call them that, the trusts who have champions dedicated to that role. Maybe you have EDI champions, but you spread it amongst a few people who cover those characteristics to do that, or maybe not even cover those characteristics. Maybe you look for people who are completely opposite, so that you're getting a different perspective perhaps. I know some people might find that quite controversial. I've put these two up there because my brain feels like that constantly on the left-hand side. Just keep it simple. Don't feel you, because sometimes people, I think, feel overwhelmed that there's too many groups to deal with. We just can't do this. Just start small, but start somewhere. I've used a roundabout on the right-hand side. I call this roundabout paralysis. I'm quite impressed with myself with this term. I don't know if you've ever got to a roundabout and the 3 or 4 of you stop there and you all stop at the same time and no one moves, and until eventually someone does move. And sometimes I think that when we work in general practice, it's pretty similar. We're all waiting for someone to make that move, and all I'm asking you to do is listen, let's just keep it moving. So what I've done is I've included some useful resources which I'll send to you. One of my favorite ones here is the transactional website. If you can go to this website, there's a resource under downloads which looks at, it's for general practice and how we as our primary care staff should engage with people from the trans community. It's a really, really good document. And this is only, I'm conscious that I've been speaking really fast and I've not really tried to engage as much as I thought I would do because I wanted to get it all out, but we've still got a few minutes to the end for discussion. But there's other workshops that are happening, and this one's coming up in a couple of weeks with the Derbyshire LMC. It's slightly longer than this and probably we'll have a little bit more, which I think I am going to try and attend this one as well. So I'll send, it's on the links on the final page as well. So I think that's it. So I did have this last slide and I forget the author because I said I've got too many tabs open, but it's called the Crayon Box. And it reads something like this: wouldn't it be terrible? Wouldn't it be sad if just one colour was the colour that we had? If everything was purple, red or blue or green, if yellow, pink or orange was all that could be seen. Can you imagine how dull the world would be if just one single colour was all we got to see? So thank you very much for your time. I appreciate it's in the middle of busy days. If anyone's got any comments or questions that I can try and answer, then I am more than happy to.